Now, baroreceptor and the sympathetic nervous system. They act by changing the activity of the sympathetic and parasympathetic nervous system. They are responsible for rapid moment-to-moment regulation of BP. Renin-angiotensin-aldosterone system. This is the kidney which provides a long-term control of BP by altering the blood volume. Baroreceptors in the kidney will respond to reduced arterial pressure, and it will release the enzyme renin. Low sodium intake and graded sodium loss will also release renin. Renin will convert angiotensin to angiotensin 1, get converted to angiotensin 2 by the use and then in the presence of angiotensin converting enzyme ACE. Angiotensin 2 is potent vasoconstrictor, both arterioles and veins. Angiotensin 2 will exert vasoconstrictor action and increase GFR. Angiotensin 2 will stimulate aldosterone secretion and increase sodium reabsorption, increasing blood volume, contributing to increase in blood pressure. Treatment strategies. These are the guidelines. ACC/AHA 2017 guideline, demographic, non-elderly and elderly, 2 guidelines. For non-elderly, if your BP is 130/80, less than 130/80, which is the goal, you have to maintain your BP. Initial drug therapy is thiazide diuretic, ACE inhibitor, ARB, calcium channel blockers, and for black, thiazide diuretics or calcium channel blockers. This was the drug of choice. For 65-year-old patients, goal is to bring BP minimum 130/80, and you have to use clinical judgment on BP control and drug choice if serious comorbidities are there. Then ADA 2017, if the population is diabetic population, you have to just bring one below 140/90, ACE inhibitor or ARBs. And then for CKD, chronic kidney disease with no proteinuria, ACE inhibitor or ARB, and proteinuria same. For general non-elderly, thiazide diuretic, beta blocker, ACE inhibitor, ARB. These are the guidelines of ESC 2013. Okay, now these are some old guidelines. We have to just remain in these 2017 guidelines. We can just remain, and you have to be more updated for 2024 guidelines. Now, individualized care drug classes indicated in treating hypertension. If you have a concomitant disease, stable ischemic heart disease, go for beta blockers, then ACE inhibitors, then ARB, and then last calcium channel blockers. Diabetic, first is diuretic, then ACE, ARB, and calcium channel blocker. Recurrent stroke, first is diuretic, then ACE and ARBs. Heart failure, first is diuretic, then beta blockers. If you have a heart disease, then only you will go with beta blockers. Otherwise, these are not the choices in hypertension. ARBs. Now, actually the hypertension choices are diuretics, but if you have a kidney disease, then no diuretics. You have to directly go for ACE inhibitors or ARBs. Angiotensin renin blockers, angiotensin receptor blockers. Now, diuretics. First is thiazide diuretics. What does it do? Decreases BP by decreasing retention of sodium, decreasing blood volume, decreasing cardiac output, and decreasing peripheral resistance. Both of them are decreased and decreased in BP. These are the thiazide diuretics. Now, there are also classified as loop diuretics, which are furosemide, torsemide, butamide, ethacrynic acid. They block sodium and chloride reabsorption. Unlike thiazide, loop will increase calcium content of urine, whereas thiazide will decrease it. This is the main difference between both of them. Potassium sparing, spironolactone, and the other, all of these will reduce the potassium loss in the urine. Therefore, they have additional benefit for cardiac remodeling that occurs in heart failure. Potassium sparing diuretics are sometimes used with loop and thiazide to reduce the amount of potassium loss, because they will lose the potassium, but this will reabsorb it.